So I've been asked to speak about a lumbar discectomy, the standard open approach, and how I do it. Okay, sorry, the photos haven't come through, but so yeah, there are many ways to do a lumbar discectomy these days. In fact, the first lumbar discectomy, which was performed in 1934, was actually through the dura. That's not done now, except in very, very rare cases where a disc does protrude through the dura. But the most common way is an open approach and using magnification or the microscope. So I use the microscope. There is a game changer now, though. There's an endoscopic approach to doing a discectomy, which I think is going to be revolutionise this operation. And there's also a variant of the open approaches, which is the far lateral for the far lateral discs. So again, my usual technique in how I approach surgery is you select the right patient. When we're at surgery, we do a timeout. Very important because we need to make sure we do the correct level and the correct side. Positioning, marking the level, opening, foraminotomy, discectomy, and closure. So with the patient selection, this is the most important, again, aspect to deciding to do surgery. First of all, with all spine, you've got to decide, is this disc prolapse the cause of the problem? There's no use operating if it's not. And if it is the problem, then is surgery via a discectomy an option? So there are operative factors such as, is the disc soft? Are you going to be able to take it out through this specific operation? The other factors are patient factors. So their clinical presentation, surgery is pretty much a last resort with disc pathology like this. So if they've failed conservative management, or if they, and that's usually about 8 to 12 weeks that they should really be improving. But surgery can occur before then if the pain is intolerable, the patients have other things to do, they want to get better quicker, if there's significant weakness such as a foot drop, or there's quarter-equina syndrome that's real or impending. And then the other factors are they fit for surgery and whether they want surgery. So most of the disc prolapses are in the posterolateral aspect of the disc, and they affect the traversing or the lower nerve root in the lumbar spine. In up to 10% of cases, they can be foraminal and they affect the exiting nerve root, and they're they can be very painful with a very small disc because it's at the narrowest point of exit through the nerve from the bone, and it affects the dorsal root ganglion. If the disc is more of at an axillary level, then it may affect both nerves. So with a timeout, we get ourselves ready. I usually open with a headlight and sometimes magnification. But then after I've done that, then I turn and I listen to the timeout. I have seen a case where the wrong patient's films were put up, and the theatre tech actually pointed that out, and that avoided major issues with doing the wrong operation. So this is, I think, a very important aspect, and it shows respect to the whole team. You can let the anaesthetist know what you're thinking, whether it's a redo, risk of a CSF leak, do they need to be lie flat if afterwards they need a catheter, etc. Is it going to be a hard operation? And the anaesthetist can also let you know, he's difficult to ventilate, the things that we can foresee it's going to be an issue with the surgery. So with positioning, classically the patient's placed prone, although there have been in earlier situations where patients have been formed laterally, and sometimes that can be the case when patients can't be ventilated in the prone position due to obesity. So they're placed on the Wilson frame. When rolling over the patient, we use spinal precautions. We take note that usually if they've got a very bad back, patients will probably have a very bad neck as well. So If there's any suggestion on history taking or exam that they might have issues with myelopathy, always image beforehand so that you know when you whether you need to manage that first or if it's at risk of issues when you're turning the patient. I wind up the Wilson frame a little bit, but not too much. Certainly in lumbar decompressions for fusion surgery, I leave it down because I want to recreate the lumbar lordosis. Because we find that sometimes, I also think that when you have the patient more lordotic, it makes the decompression bony removal harder, but at least that's sort of where they're going to be when they're walking. So people don't walk with their back flexed. And so then that gives me a real sort of feeling of whether the nerve's compressed or not. Pressure area protection, as you know, with the prone position, there have been cases of blindness occurring. With the male patients, make sure the testicles are cleared and the gel pads applied don't go over the hip replacement. And also patients with pacemakers, be aware of that when using monopolar. And next is the important level check. This can be undertaken preoperatively if you don't want to waste time waiting for the radiographer. You can use carbon markers or methylene blue markers. It gives an added, I guess, not nice procedure for a patient preoperatively. I use an image intensifier intraoperatively, and I use 3 19-gauge needles because sometimes patients are quite fat and you can be really off with if you just use one needle. And so I don't want to waste time having to do a number of shots. I get an intra-op image, and I use a Watson chain or an artery forceps to mark the level. But beware of transitional vertebrae. It can be sometimes very difficult to see if you've got the right level, particularly if the II shot's not that great, the patient's very fat, you've got someone who's having trouble, you've got a junior II person. It's always good to have a good second pair of eyes, so have an experienced assistant with you. So with opening, I'm able to do a very small incision for thin people, sometimes slightly bigger incision for larger people. We dissect down the ipsilateral side of the spinous process to the lamina. I use a Watson chain dissector under the lamina, except in situations where it's very, very tight, then I'll use an artery clip into lamina. But the Watson chain is very good because you can really see it's very firmly placed. You can see it's definitely under that a particular lamina, because again, it can be tricky if the shot's not that great. And as I said, best to do an intra-op X-ray. Don't count up or down because mistakes can be made by counting, and have your assistant check. I use a marker myodine retractor, but tubular retractors or Versatrac, particularly large patients, can be used. So then we do the foraminotomy. We drape and bring in the microscope. I use an M8 burr to do the foraminotomy. I always do a medial facetectomy, purely so that I can get lateral to the nerve root, and I'm not having to really retract hard on the nerve root to get to the disc prolapse, particularly if it's a large one. Using Kerrison rongeurs as well, we remove the ligamentum flavum. Make sure you identify the nerve root. It can be really tricky sometimes, particularly with nerve roots that are stuck down. They can look like the disc. Always make sure that you see where the nerve root comes off the dura. I've seen people incise into nerve roots, and even when I do the incision into the disc, I always make it longitudinally in case I encounter a nerve root, in which case then you're not transecting the nerve. Use a Watson chain to feel the disc prolapse, and again, as mentioned, be aware of the overlying nerve root. You can get dural tears in the small foraminotomy. They're a nightmare to try and suture. in that case, then I remove more bone, make sure I put a patty over the breach quite quickly to avoid CSF loss and extra bleeding from the epidural veins. So with the discectomy, I do a small cruciate annulotomy to try and prevent a large hole being left and therefore risk of recurrence. I remove the fragment and any intradiscal fragments. One of my bosses, when I was learning, used to scrape out the whole disc to prevent recurrence, but I think there's a fine line to deciding how much to remove and how much not to. There is some talk that there might be a risk of discitis afterwards, but certainly there could be a risk of instability if you're very aggressive with your disc removal. Be aware of there can be large vessel injuries anteriorly if you're going in with your decker. Make sure you've got it closed when you insert it into the disc space, because it can be deceptive as to how deep it is to get to the anterior space where the large vessels and bowel is. So there have been cases where inadvertent large vessel injuries have occurred. Sometimes it's brought to the attention by a latent drop in blood pressure. You don't necessarily see blood come up through the disc space straight away. If people have got slips, be aware that the distance to the vessel or bowel can be a lot shorter. If you don't find a disc at the time that you're looking for a discectomy, always recheck the level, check the date of the scan. Could the disc have healed up in the meantime? You just need to extend the corridor because you have to find this disc. If you don't find a disc, then I take another shot with my Watson chain in the annulotomy to make sure that at least I'm at the right level or the intended level of surgery. So then we form a rhizolysis. So always make sure I decompress the dorsal root ganglion. So that's the expanded area more laterally on the nerve root, because any compression of that nerve root can lead to residual pain. Then get hemostasis. I use flow seal, but if that's not available, gel foam's very adequate. I use topical dexamethasone more for me than anything else, but I sort of see it as a direct cortisone injection at the time as an added bonus. I don't think it impedes healing. Possibly it might lead to extra tethering and scarring, but I've not really noticed that currently with my patients. I do notice that a patient who's had a number of cortisone injections before surgery, that there does seem to be a fair bit of tethering, whether that's due to cortisone or whether it's just due to the duration that the patient has had an inflamed disc. It's up for conjecture. So make sure the epidural bleeding has stopped. Whether to put a drain in if there's a lot of bleeding. It's almost, I've not needed one for lumbar discectomy, and particularly there's issues if you've got a CSF leak. If the count's incorrect or you think there might be a retained body, I always do an X-ray afterwards to make sure we haven't left it inside the patient. And post-op, I have no sitting for more than 30 minutes to decrease the pressure on the disc and risk of more disc prolapses. Patients just walk, no core strengthening, get staples out day 10. These cases now at Royal Melbourne we're doing on our 23-hour ward, but certainly they can be done under local anaesthetic or as day cases as evidence in the States. Then we see them 6 weeks afterwards for post-op review, then start physiotherapy, etc. Avoid bending, twisting, the standard things. There are post-op complications that can occur, the pseudomeningocele that can be either asymptomatic or symptomatic if they're larger. Blood patches can be used. I have only used it once and I regretted it because I ended up needing to go in because it just didn't work, and then there was blood causing compression, etc. I tend to be more aggressive and rather go and open the patient to look for the site of the dural leak, because the patient is happier because you've dealt with the problem quicker, and I feel happier too. Post-op hematomas can either occur immediately post-op if someone has a lot of pain, back pain and or leg pain. Be aware that it's not just them. Have in the back of your mind, is it a hematoma? And another scenario might be when they start Clexane about day 2, day 3. They might already have a post-op hematoma and it's just tipped them over. Recurrences vary from about 3 to 15%, usually at the same level, same side. Smoking, diabetes, large disc protrusions, and obesity can be slightly predominating in these for the risk of this. And finally, just the far lateral approach, which I'll just touch on because I was meant to just talk about standard approach. This is for far lateral disc herniations and where there's a pars defect, because you don't want to do a medial facetectomy in a patient who has a pars defect, even unilaterally, because you're going to add to the instability for that patient and therefore maybe lead to needing a fusion. So the incision is paramedian, about 2 or 3 centimetres from the midline, dissect down, and the key is to get the intermuscular plane between multifidus and longissimus. I use blunt dissection, feel for the transverse process. So you're on the lateral side of the facet joint. With this approach, bring in the microscope, identify the pars and the articular facets, and you should be able to palpate the foramen and enlarge it if as required, depending on where the disc prolapse is. Then the key is to find where the nerve is. So long as you know where the nerve is, you can protect it and you're not going to injure it, because it can be a bit, especially when you're new to the technique. And then we use a nerve hook to palpate the inferior aspect of the pedicle and superior inferior aspects of the nerve with an annulotomy. There is a higher risk to trauma to the dorsal neuroglycan ganglion with this operation as well. And that's it. Thank you.